All right, today we're tackling something that can be a real surprise for parents to be during a prenatal ultrasound, a ureterocele. Now, I know that word sounds pretty complex, right? But don't worry, we're going to break down exactly what it is, how doctors figure it all out, and the amazing ways they can treat it. So let's get right into it. So picture this, you're an expectant parent, you're at a routine scan, and you see an image just like this one. There it is, a tiny little bubble inside your baby's bladder. You're probably thinking, what in the world is that? And what does it mean? Well, that is the exact question we're going to answer today. Okay, so first up, what exactly is a ureterocele? Let's get a simple explanation. So let's think of your baby's urinary tract like a plumbing system. It's pretty simple, really. The kidneys make the urine, and these tubes, called ureters, act like pipes, carrying it down to the bladder. Now, a ureterocele, it's basically like a little water balloon that forms right where that pipe enters the bladder. It's a swelling, a bubble, and because it's something a baby is born with, we call it congenital. All right, let's run through a few key facts here. We've already said it's congenital, meaning it's there from birth. It's basically a cystic dilation. That's just the medical term for that bubble-like swelling. What's interesting is that it shows up more often in girls and almost exclusively in Caucasians. And in about 1 out of 10 cases, it's bilateral, which just means it affects both ureters, not just one. Okay, it's also super important to know that not all ureteroceles are created equal. They come in 2 main flavors. You've got orthotopic, which is the simpler kind. It's all contained neatly inside the bladder. Then there's ectotopic, which is a bit more complex. This one can actually stretch down toward the bladder neck or even the urethra. And this ectotype, it's often connected to something called a duplicated collecting system. It sounds wild, but it just means a single kidney has 2 pipes or ureters coming from it instead of the usual one. All right, so how do doctors actually figure this all out? How do they go from that one little clue on an ultrasound to a full-blown diagnosis? Let's get into the details. Funnily enough, the first clue usually isn't the uretocele itself. It's what's happening upstream. The journey often starts right here, with a prenatal ultrasound showing something called hydronephrosis. That's just a fancy word for a swollen kidney. Why is it swollen? Well, because that little ureterocele bubble is acting like a dam, blocking the flow of urine and causing it to back up. It's pretty amazing, really. This is modern tech giving us a crucial heads up, long before the baby even arrives. But that prenatal discovery is just the starting point. The real detective work kicks in after the baby is born. So what happens then? This is where the medical team starts putting all the puzzle pieces together. After birth, another ultrasound gives them a really clear look at that bubble in the bladder. But then they bring in the big guns, a specialized X-ray called a VCUG. What they do is use a special dye to light up the urinary tract. This lets them see the ureterocele's exact size and, crucially, to check for something called reflux, which is when urine flows the wrong way back up towards the kidneys. So this is basically the diagnostic trifecta. You've got the ultrasound for that first look, then the VCUG. That's short for a much longer name, don't worry about it, which is key for checking reflux and getting the lay of the land. And then the DMSA scan. This one is huge. It's a special test that tells doctors exactly how well each part of the kidney is working. All this info together is absolutely critical for figuring out the best way forward. Okay, with all that diagnostic info in hand, it's time to map out a plan. And the most important thing to remember here is that this is a totally personalized approach. I mean, this quote really says it all. No single method of surgical repair is appropriate for all cases. And that's such a crucial point. Every single child is different, their anatomy is unique, so the treatment plan has to be custom-built just for them. It's not a one-size-fits-all situation, and honestly, that's a very reassuring thing to hear. So what are the big factors that go into making that decision? Well, they're looking at the child's age, of course. They're looking at the ureterocele itself. How big is it? Is it that simpler orthotopic kind or the more complex ectopic type? They're also asking, is it causing other issues like reflux or nasty urinary tract infections? But maybe the most critical piece of the puzzle is that kidney function. How well is that part of the kidney actually doing its job? All right, let's talk solutions. When it comes to treatment, there's a whole spectrum of options, ranging from really simple procedures all the way to more complex reconstructions. But really, we can group all those options into 3 main strategies. First, you have decompression. Think of this as the simplest fix. It's a minimally invasive way to just relieve the pressure. Then there's reconstruction, which is a more involved repair of the bladder and the ureter.
And finally, you have removal. This is for when a piece of the kidney just isn't working, so they can remove it, and often that solves the whole problem right there.
So let's look closer at decompression. This is really neat. It's minimally invasive, which means they go in with a tiny scope, like a little camera, right into the bladder. They make a tiny little cut in the ureterocele and pop! Just look at the before and after here. The bubble collapses immediately. Just like that, the blockage is gone and urine can flow freely, and often the baby can go home the very same day. Now, for some of the more complex cases, reconstruction is the way to go. This is more like a full-scale remodeling project. The surgeon actually removes the ureterocele tissue, rebuilds that part of the bladder wall, and then carefully reimplants the ureters so they drain properly. The whole goal here is to build a urinary system that's as close to normal as possible and will work perfectly for the rest of the child's life. And then there's our third option, removal. This is where that DMSA scan we talked about is so important. If the scan shows that the top part of the kidney just isn't pulling its weight, like we see here in image A, then sometimes the most elegant solution is to just remove that non-functioning part. And what's amazing is, once you take away the source of the problem, the whole system down below, including the ureterocele, often just fixes itself. It's pretty incredible.
So no matter which of these paths is chosen, the end goal, the finish line, is always the same. So let's talk about what success really looks like. Ultimately, it all comes down to this checklist. Number 1, preserve as much kidney function as possible. 2, get rid of any blockages or reflux to stop infections in their tracks. 3, make sure the child has normal bladder control as they grow up. And you want to do all of this with the safest, least invasive surgery you can. It's all about setting that child up for a perfectly healthy future.
So when you step back and think about it, it's really something, isn't it? We've gone from a tiny, subtle clue on a prenatal scan all the way to a completely personalized treatment that can restore normal function for an entire lifetime. It's just a fantastic example of modern medicine at its best. I mean, how amazing is it that we can find a condition before a baby is even born and then treat it with this kind of incredible precision?